Professor Christoph Nienaber is a renowned professor of interventional cardiology at the Royal Brompton Hospital. He's been published prolifically and teaches widely. He helped to set up the first integrated Marfan clinic in Germany, and one of his special interests is intervention and keyhole treatment of acute aortic diseases. Today, Professor Christoph will talk of treatment for type B dissection.
Thank you, Victoria. It is a great pleasure to be invited to this forum. I'm afraid I'm seeing some of my patients watching me today. Can you see my screen?
Yeah, with your optimistic backdrop. Keep calm and carry on.
All right. Okay, my slide as well?
Not yet, no.
Okay, I'm trying to share it. It should come up now.
Yep, we can see it. Thank you.
Okay, I have slightly modified the title because I'm in this forum, probably not, it wouldn't be appropriate to just talk about type B dissection and endovascular treatment of it. I wanted to really share half an hour with you talking about the screening, surveillance, and management of patients with aortopathies, including, of course, patients with connective tissue disorders. We are in the beginning of a trend that changes in the sense that living with a condition and working and learning with a condition throughout the whole life, we experience changes in the medical treatment, changes in options to choose from, and changes in life expectancy with better treatment. I show this slide. I like to show this slide because it illustrates one of the pioneers in the world of aortic dissection. You can see down there on the left-hand corner, Dr. DeBakey at the age of 95. Dr. DeBakey, for those who don't know, that created the DeBakey classification of aortic dissection. And he succumbed to a tremendous experience of chest pain at the age of 95. He was still in the hospital seeing some patients or doing some work, not necessarily on a rotational service, but he was always present. And he was eventually diagnosed with a type 1 DeBakey classification dissection, as you can see on that slide, with a tear in the ascending aorta. And realizing what dissection means for a person of his age and with his life, he was hesitant to undergo surgery. It took his wife 4 weeks to convince one of his students, George Nunn on the right-hand side here, to operate on him. It was even more difficult to find an anesthetic to put him down to sleep for this operation, but eventually underwent a successful operation, as shown on the right-hand side, and he survived another 3 years. Just to open the discussion on dissection, it can occur at any age, in elderly patients, in very old patients, and of course in young patients with connective tissue disorders in particular. I show you this slide here, which I think is an eye-opener for a condition that Dr. Rafik has already mentioned. If you look on the right-hand side of this slide, most of you detect immediately that there is an aortic dissection in the aorta at the level of the chest, as you can see here, with a line between the two, the proximal, the distal dimension of the aorta. There's clearly a dissection, and also there's a baby here in the womb about to be delivered. So the problem of dissection and pregnancy is very nicely highlighted in this real-life MRI scan. However, what is the dimension of this problem? In the International Registry of Aortic Dissection, with about 8,000 patients listed and collected over the years in various countries, of these 8,000, only 27 had a dissection during their pregnancy. That's a very small number. But on the other hand, having a dissection while you're pregnant is a difficult situation, difficult to deal with, difficult to manage for the mother and the unborn child, of course, and also a reflection of probably some connective tissue disorders, only diagnosed and suspected during pregnancy with that complication. But dissection of the aorta is not the only complication that can occur in patients with connective tissue disorder. There's also quite frequent, among those cases of dissection, a quite frequent incidence of coronary dissection, 37% or 38%, aortic dissection in 20%, vertebral dissection 22%, and some other dissection. So dissection of the arterial tree can be a problem. It's very rare, but it highlights obviously a non-diagnosed hereditary connective tissue disorder. Having an aortopathy is a difficult situation once you're aware of it, because it may impact on your quality of life. It may impact on your mental health. And I like to show this little video. Having an aortopathy may be like a problem in midair. You have options. You can watch and wait. You can carry on flying. You have enough gas. And if there is no malperfusion issue, you can have options from medical management to intervention or to prevent something to occur. And in terms of prevention, the discussion currently in the medical circles and the guideline committees is about integrating parameters that are easy to extract from images, such as dimensions, length, genetic profiling, and put this into a context of preventive surgery or preventive medication. We have heard already that preventive medication is usually a combination of a beta blocker and a ACE inhibitor or a sartan, the newer generation of ACE inhibitors. The combination of both is obviously the best to prevent slight dilation and progression of aortic dimensions. But if it comes to a certain threshold, I think surgery is still inevitable, although no surgery is probably the best surgery you can ever have. Nevertheless, the medical community and the guideline committees show a trend and published a trend some years ago in 2018 to a recommendation to an earlier intervention as long as certain genetic diagnoses are confirmed. For instance, if there is a mutation in the TGF-beta pathway genes, no matter which one, the trend goes to earlier operation at the level of 4.5 centimeters, as already mentioned, particularly for patients with a clinical phenotype of Loeys-Dietz. I don't want to go into more detail. The trend here is, or the message here is, that an earlier intervention seems to be the current trend, although I personally feel as long as justified, an operation should be postponed or delayed until necessary. I think we don't have to dive too much into this. The various features of Marfan syndromes are well known. They have been alluded to in previous talks. I just want to mention that the prognostic impact basically is related to vascular involvement, to aortic involvement in particular, and the aortic root, as shown here, is of particular interest for preventive interventions and preventive surgery. But it's not only the dimension of the root. We have discovered recently, various teams, and I had the luxury and the privilege to write an editorial on it, that there is also other features, in particular for Marfan patients, that need to be taken into consideration if it comes to predicting dissection, or to at least predict or identify a patient at risk for some vascular complications in the future. And that is, for instance, the length of the aorta measured from the root or from the level of the aortic valve to the first side branch here, the so-called innominate artery. If that dimension extends more than 11 centimeters, you are dealing with a patient who may actually have a vascular accident in the future, irrespective of an underlying connective tissue disorder or just a normal hypertensive patient. So this is a new dimension that needs to be taken into consideration. Loeys-Dietz is another example of an hereditary connective tissue disorder that affects the aorta and the vascular system. We have spoken about this in earlier meetings. It's just to highlight that genetic underpinning is important to diagnose, obviously triggered by some phenotypic suspicion, but the knowledge of the genetic underpinning is always important to, again, improve the risk profile of a given patient. And this is another example that shows you the typical features often seen in Loeys-Dietz syndrome. Not everybody has this dramatic phenotype with scoliosis to this extent, with vascular tortuosity, as shown here on the right-hand side. But some patients have, and they need particular surveillance and attention and imaging within a year and follow-up clinical appointments to see whether some slight phenotypic changes are corresponding or are accompanied by changes in the vasculature, particularly the aorta. Here's a patient that I like to demonstrate and basically shows you the option that we have today available. A young patient being diagnosed with Loeys-Dietz who underwent various operations in the past, total of 4 thoracotomies to fix not only the aorta but also to repair the mitral valve. He had an elephant trunk that you can appreciate here, and eventually developed a type B dissection, which classically would be subject to an open repair, but the patient, of course, wouldn't accept that and didn't accept that, and basically was almost 8 years ago or 9 years ago subject to an endovascular procedure with a nice result and an endograft placed percutaneously through his left leg artery into the thoracic aorta and fixed the dissection and the forming aneurysm here that you can see. The trick is here to find the way up the aorta in the very narrow true lumen and position the stent in the true lumen and reconstruct basically the true lumen by closing the communications to the false lumen. The false lumen, which you can see here, filled with contrast or blood, is completely isolated from pressure and flow, and thrombosed, eventually stabilizing the aorta further. So there's options available in the last 10 years that we can use in some of our patients, even in patients with hereditary connective tissue disorders, as exemplified in this previous case report. Other interesting aortopathies comprise aortic coarctation. Aortic coarctation is a congenital malformation of the aorta with a narrowing or sometimes an occlusion in the descending thoracic aorta. It often associates with a bicuspid aortic valve and a dilated aortic root. So these patients, when they are identified with this feature, need also to be imaged in their ascending aorta for potential later repair if the aortic root dilates or if the valve becomes incompetent. But the primary treatment strategy would be to abolish this narrowing, this almost obstructive pathology in the descending aorta in order to avoid hypertension in the head vessels, hypertension to the brain and the upper extremities. In most patients, natural collaterals develop to connect from the upper part of the aorta to the lower part of the aorta and provide enough oxygen supply and blood supply to the abdominal area, to both legs, to the kidneys, etc. But if these patients remain undiagnosed beyond their early years in childhood or at the time of adolescence, they end up as early or young adults in the adult cardiology clinic, and we can identify them relatively easily by measuring the differential blood pressure between the arms and the legs. Most patients are introduced to the clinic by having a juvenile hypertension, and nobody paid attention to the blood pressure in the legs, which would have given the easy diagnosis of this congenital problem. But measuring blood pressure in legs is probably not often used by family medicine and GPs. So the problem ends up in the specialty clinic with a juvenile hypertension, which in fact is not hypertension, but rather an obstruction of the aorta. It can be treated non-surgically with a stent. The stent can be placed at the level of the narrowing and opened under pressure, under balloon pressure, and reconstruct the aorta in this bit here to equalize the pressure in the upper part of the body and the lower part of the body. That's very important because high blood pressure in the upper part of the body in young patients or young adults set them up for later stroke and aneurysm formation in the head vessels. I mentioned already bicuspid aortic valve aortopathy, which is a malformation of the aortic valve. It has 2 cusps rather than 3, as in a normally formed aortic valve. There's in some cases a family history, obviously an autosomal dominant trait. It's worthwhile screening first-degree family members if you have a patient with this pathology. pathology actually doesn't mean necessarily that the patient conducts a different life. It just needs to be monitored carefully, and in case of dysfunction of the valve, it may be reconstructed or replaced. Not every valve is dysfunctional. You can live a normal life with a bicuspid aortic valve. However, you need surveillance, or the patient would need surveillance. And in case of deterioration, or in case of any kind of later problem in life, it needs proper attention in a specialized center. Those valves can be reconstructed by an experienced aortic surgeon or can be replaced by usually a biological valve replacement. There's various forms of associated aortic changes. Let's assume this valve narrows with time and the jet through the valve becomes kind of pinpointed and reaches to the outer curve of the ascending aorta. This kind of pathology, type 2 or type 1, is more likely to occur. If it's a true aortopathy and usually connected with genetic underpinnings, you find this globular aortic valve and aortic ascending aortic aneurysma formation, which is prognostically more difficult and more dangerous because it requires valve replacement and replacement of the ascending aorta as well. The bicuspid valve has also some interesting features that are different from a tricuspid aortic valve. If you focus here on the right-hand side, on the upper image, you see a normal flow pattern in the aortic valve, aortic, ascending aorta, aortic arch, and descending aorta with so-called laminar flow. That means equal flow throughout the entire structure of the ascending aorta, descending aorta. Whereas in bicuspid aortic valve pathology, the jet becomes non-linear and pounds against the outer curve of the ascending aorta, causing sometimes early degeneration, early expansion, and the formation of an aneurysm. This needs to be picked up before any kind of symptoms occur because the pathology itself is completely asymptomatic, but we have tools now with MRI and with echo to identify the impact of some bicuspid aortic valve pathology. As I said, not every valve needs to be replaced or refashioned, but some of them do because they traumatize the ascending aorta by the jet. Bicuspid aortic valve is another interesting area that now is under research in terms of genetic underpinnings. I said that it's easy to identify a family history by carefully asking for second and first degree family members and screening them with echo. But again, there's a host of different, obviously different mutations already found in the so-called non-syndromic as a part of bicuspid aortic valve conditions, which have obviously some sort of relationship to given mutations identified and published in certain families. What I wanted to say here at this stage is that not every bicuspid aortic valve has a clear-cut genetic underpinnings, but the more we look at this black box, the more we identify potentially associated gene mutation that may actually lead the way to an earlier diagnosis in patients that have no phenotypic features. Again, in terms of preventing catastrophes in the future, if the ascending aorta is subject to dilatation, or if a patient has a higher risk of dissection, such as a patient with connective tissue disorders, it's worthwhile thinking of a preventive surgical support system. I think Dr. Warafik has already mentioned the Pierce procedure, which is a wrapping of the ascending aorta, the most frequently affected part of the aorta that can suffer from early expansion or from dissection. I have to say at this stage that not everybody, even with Marfan syndrome or any other connective tissue disorders, has a risk of dissection. On the other hand, patients, irrespective of their genetic underpinnings, can dissect at the level of the ascending aorta, even at a normal dimension. In the International Registry of Aortic Dissection, we have published some 10 years ago that 45% of patients with ascending aortic dissection dissect at a level which is considered to be normal. Patients, of course, that you would not consider candidates for preventive surgery or for valve-sparing root replacement operation because their level of dimension or the level of the max dimension of the ascending aorta is below the threshold. the threshold, as I mentioned initially, is moving slowly to the left, accepting patients with a 45 or 50 millimeter threshold. But again, 45% of type A dissection happen at a level below 40 millimeters. So it's very difficult to identify a patient for such a procedure. Potentially a patient with Marfan syndrome who wants to become pregnant is an ideal candidate for it. However, the operation itself is not trivial. It's not an easy operation. I'll show you a picture in a minute, but it is a very stimulating idea to protect the ascending aorta with an external wrap. This is a patient, the first patient who ever underwent a Pierce procedure. It's a male patient with a 49 millimeter ascending aorta or root dimension. At the time, on the day before the Pierce was implanted or wrapped around his aorta, and this is 10.5 years later. He's getting a new MRI next month. I'm going to see him and I will add a new MRI scan to this picture here, 19 years after the implantation of the Pierce, and hopefully we won't see any change. After 10.5 years, there was not even a millimeter larger dimension at this level, and I hope that 19 years later, you won't see anything else. This shows you, this graph here in the upper corner shows you that this is not a trivial operation. It's not just wrapping something around the aorta. It needs a hole and a personalized adjustment to the anatomy of a given patient based on a 3D reconstruction of the CT images. Then the wrap is manufactured according to the specific needs of any given patient, and a qualified surgeon, not every surgeon, not every heart surgeon, a qualified heart surgeon can basically fit this jacket around the ascending aorta and the aortic root, leaving some space for the coronary arteries, which is very important, not obstructing the coronary arteries or squeezing them in a way. All this can cause problems in young patients that are completely asymptomatic at the time of this preventive operation, so to say. So here again, a summary, the three-dimensional reconstruction from a CT scan, the personalized and individualized wrap, the surgical result, and here a long-time follow-up of this patient. Speaking about repair techniques for the ascending aorta, I think we cannot talk about this without mentioning Sir Magdi Yacoub and Taran David, who both are surgeons now in their 80s that invented very important steps of operating the ascending aorta in different techniques. They are similar but quite different in the sense that the valve-sparing root replacement initiated by Sir Magdi left the coronaries, the space between the coronaries open with natural tissue, whereas with Taran David's technique, the entire ascending aorta down to the root was supported from outside. Another pioneer in this field is Sir Hans Borst, a German cardiac surgeon who invented the so-called elephant trunk. If the aorta is affected both in the ascending and the descending part, the operation is not final once the ascending aorta has been replaced. And with the idea of leaving basically a landing pad for the second operation, he invented the elephant trunk. It looks like an elephant trunk dangling down the aorta. This concept has been embraced by various groups in the world and refined, but the idea is still his idea of supporting the descending aorta, which is also subject to changes over time. So once you have an aortic condition, you need lifetime surveillance and lifetime checks in order to observe asymptomatic changes in other parts of the aorta. It's very important. The dangling aortic elephant trunk has been also refined with a new concept of frozen elephant trunk. Frozen because it's put in during an operation as a stent. Basically, you don't need to open the lateral chest. You can just insert it from the front entrance to the chest down to the descending aorta in order to take care of, let's say, dissections in the descending aorta in association with a dissection in the proximal aorta. So this concept has been refined and is now available in the so-called hybrid room as an add-on to an arch replacement or ascending aortic operation. This is the environment that we use to work with surgeons and interventional cardiologists working closely together. And we're using CT images during the operation to find our way to the pathology. So the concept of operating in aortic conditions has changed to a more hybrid scenario where interventions and surgical repair meet doing the same operation. Because type B was of specific interest in this talk, I have the privilege to show you the most recent guideline recommendation in the treatment of type B dissection. The guideline recommendation will be launched today, I think, as we speak in Vienna at the meeting of the European Association of Cardiothoracic Surgeons. And I had the privilege to take this graph from it before it's officially launched today, probably around this hour, and published online, available, I think, on Monday. It has some new features. The so-called type B aortic dissection, you're familiar with that. It affects the descending thoracic aorta, has traditionally been separated in complicated and uncomplicated. This old concept of uncomplicated has been scrapped and is now ghosting for good. And we have only complicated aortic type B dissection, which is basically somebody with malperfusion or impending rupture of the aorta, or if the ascending aorta is also involved and bigger than 4.5 centimeters. These patients with the label complicated have to undergo immediate treatment, either by an emergent endovascular treatment, as shown before, if the ascending is not affected, or if the ascending is also too large, by an open approach with an emergency intervention using a frozen elephant trunk on top of the classic operation for complicated type B. And those that are not complicated in that sense may have high-risk features. High-risk features are, for instance, patients with ongoing pain, patients with difficult to treat hypertension, patients with a primary entry tear bigger than 10 centimeters, patients with the entry tear located in the inner curvature or closer than 20 millimeters from the left subclavian artery, and some other anatomic features. You have to basically check every patient for these high-risk features. And if they have a high-risk features, they are also candidates for either endovascular treatment or combination with an elephant trunk. Only patients that do not show complications or high-risk features are amenable to optimal medical therapy only, meaning a beta blocker and another vasodilating agent, and of course regular follow-up, imaging, and clinical visits. So in my view, the misnomer of uncomplicated dissection has been scrapped. Here's an example of a case with complicated dissection due to malperfusion. You can see the true lumen is getting narrower and narrower, and we had to put in a stent to open the true lumen and reperfuse the lower legs. That's possible. You can preserve the side branches by the appropriate choice of the stent. You have various options, and the outcome is usually very stable once the initial intervention has been survived. So it's a good option to treat patients with those complications with a 1B recommendation, means almost highest recommendation given by the guideline committee. There's other pathologies, of course, we don't have to go into detail. And most patients with connective tissue disorders, for instance, have to undergo a first surgical intervention and then later been evaluated and checked for other pathology in the descending aorta, which is sometimes difficult to operate. But luckily, technology is improving, and we have very gentle and soft endovascular devices available that can even be used in certain conditions of hereditary connective tissue disorders. So a patient who needs a second operation can be also considered for an endovascular approach, even though he or she is suffering from a connective tissue disorder. There's all sorts of options. It is very difficult and important also to analyze the blood perfusion to the spinal cord, because you can imagine if you put too many stents in the descending thoracic aorta, the supply of the spinal cord could be jeopardized. So it's important to analyze that there is enough collateral inflow from above and from below, from so-called feeder arteries that connect to the collateral network and avoid ischemia and damage to the spinal cord with the subsequent neurological consequences, which we truly want to avoid. But there, as I said, there's options. It can be staged. It can be done in several steps. There's just some images to show you that these options have been developed over the last 10 years in various variations. It's always important to keep side branches open and, of course, feeder flow to collateral networks of the spinal cord. But even complex pathology can be tackled now with endovascular solutions. It's usually a cooperation between vascular surgeons, interventional cardiologists or radiologists, and cardiac surgeons who use the environment of the hybrid suite that you saw before to operate on these cases, because you need imaging, you need intraoperative imaging, contrast echo, contrast fluoroscopy in order to see and monitor your results. This is just technical detail. The idea that we today follow is to avoid thoracotomy whenever possible. Thoracotomy means that the chest needs to be opened in order to treat a given pathology. If you can avoid that by vascular interventions such as bypass interventions to the head vessels, that doesn't require any thoracotomy, and then an endovascular approach from the leg artery to complete the procedure, then you can avoid cardiac arrest, you can avoid cardiopulmonary bypass, and of course thoracotomy, which is very important. So the trend goes to an endovascular approach whenever possible. In the ascending aorta, we have had some experience in 16 cases with even endovascular approaches to the ascending aorta, which is clearly a surgical domain. But we run into problems 16 months later. You can imagine the ascending aorta is a moving target, and the moving motion of the ascending aorta can cause erosion, and then eventually an open surgery is not avoidable. In this case, however, it was not possible to operate on this patient due to a cerebral bleed at the time of the developing type A dissection. So we elected an endovascular approach, saved the patient's life, and temporized the surgical procedure to an elective procedure 16 months later. So even though the ascending aorta is a surgical domain, endovascular treatment can be an option to temporize a problem. I talked about surveillance and aftercare and lifetime surveillance. For that, of course, images need to be stored every year and compared, because by comparing images over time, you may be able to detect subtle changes, like, for instance, the development of a new dissection line here, a slight progression of the total dimension from 2008 to 2017. And to keep all this data available and understandable, even for specialist radiologists or cardiologists, we need to store this data and actually find a new way to present it. And the new way to present these serial data is shown here. What you see here is nothing but a number of scans, of CT scans, starting from the aortic root to the bifurcation of the aorta, and lined up one after the other with changes related or documented here at various levels. This is the area of the descending thoracic aorta, and you can see here that the dimension has progressed from 39 to 41 and eventually to 59 millimeter dimension. And this display summarizes the information of a total of 3 scans over the entire stretch of the aorta, and gives you with one view the impression of a progression in certain aspects of the descending thoracic aorta that now need attention because they surpassed the threshold of 55 millimeters from 41 to 59 within 2 scans. And that is, of course, a call for arms and for action. I was privileged enough to talk about and to comment on the American guidelines on imaging in the aftercare of aortic dissection. And we wrote this slightly provocative comment to the guidelines, telling basically that I wrote this together with my colleague, Dr. Juan and Fortunat Rusiki, who is a specialist nurse. And we looked at our own data, and we came to the conclusion that imaging alone is not the holy grail of aftercare, but you need the physical examination, you need the actual clinical appointment in addition to the imaging information for proper individualized aftercare. Not only that, new information in the scan, such as flow parameters, flow velocity, and jet pressure or pulse pressure to the valve, to the aortic wall, may give another layer of information and may help to select patients for prophylactic treatment. So my take-home messages from this 25-minute talk is that the diameter threshold for preemptive surgery or intervention should likely to be adjusted to patient-specific features. You need more than just imaging. You need the personal impression of a clinical examination. And then early surgery and early intervention may be modified and individualized based on the genetic profile of a given patient. Not everybody needs to be operated at a certain threshold. It may vary from person to person, from genetic underpinning or profiling to the next patient. And I didn't really spend too much time on markers of inflammation. That's another interesting area to talk about maybe next year. There is some serological markers available now that we can use to predict patients at risk without any features of aortic dilatation, without any symptoms. So the critical appraisal for standard surveillance and aftercare. It is intriguing to incorporate markers of inflammation, potential drug effects, and certain comorbidities in a smart and adaptive risk prediction model, which we are working on. Computer simulation of future evolution is a compelling new field, but again, results need to be validated. And surveillance imaging should be embedded into a framework of multidisciplinary cooperation in an aortic center of care in a group that has experience, and risk prediction requires a holistic approach on an individual patient with morphology as one component only. And I think the paradigm shift that we're all experiencing nowadays is that we developed in the new age of civilization from hunters and gatherers to the information knowledge, the age of information and knowledge, and we're all knowledge workers with increasing wisdom, but regardless of that, we're learning more, and we have to understand our work and our patients and our goals as a whole person paradigm with mind, body, heart, and spirit working together. Thank you very much. I'm waiting for your questions.
Thank you very much indeed, Professor Nienaber. I think the chat feed is beginning to flood with questions, the first of which, Mariam's son has had a type B aortic dissection and he's struggling with persistent pain, which hasn't really been helped in any tangible way. Is there anything you can suggest?
Well, the nature of the pain needs to be understood first. It could be pain related to the aorta, which would be the worst. It could be pain related to some orthopedic matters or orthopedic problems. Some patients suffer from scoliosis and associated pain. Pain can be caused by dual ectasia. There is several causes of pain syndromes, and that needs to be understood first before a therapeutic recommendation could be made.
So to pinpoint the catalyst for the pain.
Absolutely, it needs to be understood, and sometimes the nature of the pain, the perception of the pain, can help to differentiate, but not always. I think it requires a very, very thorough view of the aorta, of a potential existence of a dual ectasia, of the narrowing between the vertebra. There's several other aspects that need to be taken into consideration, but it needs an expert to look at it.
Yeah, dual ectasia is agony. Nadine would like to know since there have been great advances in heart operations, what do you see changing over the next 10 to 20 years?
Well, good question. We have seen dramatic changes over the last 10 years, both in the surgical field as well as in interventions. I think the technology is getting more adaptive to the needs of a given patient. We're trying to personalize and individualize the approaches. There is no good one-size-fits-all recommendation. It is an individualized decision-making process involving the patient itself or himself or herself to come to a conclusion to go forward and do something. In terms of prevention, I'm more positive that preventive action will be developed, and that will be the next big step, I think, in designing appropriate drugs eliminating the activity of certain genes to pacify the process of weakening of the aorta, or stop the process of weakening of the aorta, and then basically stop the process of developing risk and enlarging aortic aneurysms. That would be my next vision, and hopefully my hope to stop the process once it's detected from enlarging and from progressing.
You. And Amanda wonders how to tell her vascular surgeon that he shouldn't be relying solely on annual CT scans to monitor her descending aorta. She had a dissection 3 years ago, and I think it was here she actually spoke to you. I remember at our information day 3 years ago, just in the wake of her dissection.
I think the lady from Scotland, right?
Yes.
Yeah, I remember. Yeah, I mean, it's a multifactorial problem. As I said, and I think we have data available to show that the dimensional changes or subtle changes in image dimension is not enough to select a patient for more treatment or for a given strategy. I think the clinical picture, the phenotypic picture, the pain description or the symptoms, not necessarily pain, but the symptoms, and potentially some imaging features together lead to the smartest decision. Some patients condition that do not allow an operation or an intervention due to other comorbidities. Others are fit enough for preventive interaction or preventive intervention. So I cannot give you an answer that fits to everybody. I think the problem will be best served in a center that takes care of many of these patients, and where the various experts work together and see many of these individuals to come to a conclusion based on data and based on experience as well. It's not only data that trigger our action, but it's also individual experience and some gut feeling sometimes.
Thank you. I don't know, I don't see any further questions emerging. I know when you spoke of bicuspid valve, that Arnold Schwarzenegger had a bicuspid valve. Did he precipitate anything with his kind of powerlifting? And
probably, well, Arnold Schwarzenegger had 4 operations. It started with a bicuspid valve and an aortic aneurysm evolving slowly. Then he had a homograft, and then he had a homograft to be exchanged for another homograft, and then he had a valve, and finally a mechanical valve. So that's the whole story. I mean, his life and his lifestyle obviously promoted the changes in the aorta, of course. Being a bodybuilder is not good for somebody with an aortopathy. Everybody knows that. But he probably didn't know the diagnosis at the time.
Exactly. And it would have inhibited, perhaps, had he known his life, which has been defined by.
Sometimes it's good to know, good not to know exactly what the details.
I think since there are no further questions, we can take our coffee break. So we're running over time. Thank you so much, Christoph. Thank you very much.
It was a pleasure.
Sneaked in. Could the aneurysm be induced or impacted by the steroids? Oh, that's from Jose.
Well, steroids certainly are known to promote weakening of any kind of arterial wall. So if somebody is on steroids with an aortopathy, chances are that the aortopathy progresses. I haven't heard of patients without any aortopathy to progress on steroids. Steroids are never a good idea unless you really do need them.
Thank you so much. Thank you for that brilliant talk.